Subscribe,
Okay, let's
friends.
dive into this. Hello, future doctors, and welcome back to today's high-yield revision explainer. आज हम एक बहुत ही crucial topic cover करने वाले हैं for your exams. Grab your digital notebooks because we are entirely focused on chronic lymphocytic leukemia, that's CLL, and hairy cell leukemia today. We're going to extract only the absolute highest yield facts that examiners literally love to test. So, focus बनाए रखना.
Here is our roadmap for today. एकदम systematically जाएंगे. First, an overview of CLL, then the pathophysiology of CLL, understanding SLL features, hairy cell investigations, and finally, treatment and associations.
Section 1, Overview of CLL. Now, what's really interesting about this next part is how these patients actually present in the clinic.
These points right here, ये direct NEET PG MCQ आता है. First off, CLL is the most common lymphoid leukemia. It affects males more than females, and here is a massive exam pearl. It's a low-grade, mostly indolent leukemia. Actually, 80 to 85% of patients are completely asymptomatic at the time of diagnosis. You'll usually see this in elderly patients. The median age of diagnosis is around 72 years. Because it's so slow growing, the median survival is about 10 years, which, can be increased with modern drugs. And super interestingly, about 1 to 2% of these actually undergo spontaneous regression. कैसे? Nature is crazy, but it happens.
एक छोटा सा एग्जाम्पल यहीं क्लियर कर लेते हैं. Don't let the examiner confuse you. While CLL is the most common lymphoid leukemia, if the question asks for the most common myeloid leukemia, your answer should immediately be AML, acute myeloid leukemia. Keep these two distinctly separate in your mind. No silly mistakes here.
Section 2. Pathophysiology of CLL. So, what normally happens to a naive B cell? Let's quickly review the baseline biology.
To understand why CLL happens, think about a naive B cell circulating in the blood. Under normal physiology, these naive B cells express a very specific set of markers. Notice these: CD19, CD20, CD21, CD22, along with CD79A, CD79B, and surface IgM. ये उनकी normal identity है. It's like their ID card. And normally, उनकी life cycle खत्म होने के बाद, they undergo apoptosis, right? Programmed cell death. Simple enough.
But pathology में क्या होता है? Let's walk through this step by step. Step 1. There's defective apoptosis. ये cells मरते ही नहीं हैं. Instead, there's a clonal expansion of these naive B cells. And here is the high-yield turning point. They abnormally acquire CD5 and CD23 markers. This leads to a state called monoclonal B-cell lymphocytosis. अब ध्यान से सुनो. When does it officially become CLL? Only when the lymphocyte count crosses 5,000 cells per microliter. Remember this cutoff. Strictly greater than 5,000. Very quickly on the etiology, just remember two major things. Number 1, there's a strong familial inheritance pattern. And number 2, ये हमेशा options में trick करने के लिए आता है. There is absolutely zero risk associated with radiation. कोई risk नहीं. So if you see radiation as a risk factor for CLL in an MCQ, immediately rule it out.
Alright, moving to Section 3, Understanding SLL Features, or Small Lymphocytic Leukemia.
So you have mastered CLL, but how exactly does it fit with SLL? Concept को समझो यहाँ. SLL actually arises from a memory B cell, unlike the naive B cell we saw in CLL. But clinically and practically, the immunophenotyping and features are exactly the same as CLL. The key difference is just the location. SLL represents monoclonal B lymphocytosis primarily in the lymph node rather than the peripheral blood. Patient आपके पास आएगा with painless asymptomatic lymphadenopathy, एकदम swollen, non-tender nodes. And yes, they can also present with splenomegaly.
Section 4, Hairy Cell Investigations. Time to look under the microscope.
Imagine you're looking through a microscope at a peripheral smear. The typical hairy cell has a very distinct morphology. It's mononuclear, with a bilobed, eccentric nucleus, meaning the nucleus is kind of pushed off to one side. And the absolute hallmark feature? Those fine hair-like cytoplasmic projections sticking out of the cell. They also have a low nuclear to cytoplasmic ratio because, well, there's just so much abundant cytoplasm. The visual is unmistakable once you know what to look for.
Now, if you do a bone marrow biopsy, you'll obviously see these hairy cells, but you'll also see fibrosis. Because of this fibrosis, the marrow can't be easily aspirated, which gives you a classic dry tap. But the real high-yield buzzwords for your exam are the microscopic patterns in the marrow. The fried egg appearance, or the honeycomb appearance. Rat Loisco. If an MCQ says fried egg appearance in bone marrow, you just mark hairy cell leukemia and move on.
And this brilliantly illustrates the immunophenotyping profile. This chart is pure gold. Positive markers include your standard B-cell markers like CD19, CD20, and CD22. But look at the specific ones: CD11C, CD25, CD103, and CD123. Annexin is also positive. But the mega high-yield fact, the one they will definitely test you on, is TRAP positivity, tartarate-resistant acid phosphatase. TRAP is positive in hairy cell. Oh, and keep in mind they're negative for CD10 and CD21.
Almost done. Section 5. Treatment and associations, because just knowing the diagnosis isn't enough to save the patient.
So, the diagnosis is confirmed. You saw the hairy projections, you checked the TRAP stain. But as a doctor, we need to know how to treat it. The absolute treatment of choice is a purine nucleoside analog. Between cladribine and pentostatin, cladribine is unequivocally the drug of choice. Mark that in red ink. If the disease relapses or doesn't respond well, we look at the genetics, specifically a BRAF mutation, and we use a BRAF inhibitor like vemurafenib. And finally, for maintenance therapy to keep the disease at bay, we use the monoclonal antibody rituximab.
Before we wrap up, I want to give you one critical final exam pearl that integrates systemic medicine with pathology. This is exactly how top rankers study. Polyarteritis nodosa, or PAN, a medium vessel vasculitis, has a known clinical association with both hairy cell leukemia and hepatitis B. Examiners love cross-linking topics like this.
So we covered the indolent nature of CLL and the hairy specifics of HCL, but let me leave you with a provocative question for your self-study. What happens when that slow-growing, asymptomatic, indolent CLL suddenly transforms into a highly aggressive, rapidly fatal diffuse large B-cell lymphoma? Do you know the name of that syndrome? Little hint for you, Richter's transformation. Keep revising, keep connecting the dots, and I'll see you in the